So today, if you look at the statistics, 1 in 3 adults, that's about, I think, 34% of all adults in Kampala has high blood pressure, hypertension. So doctors see up to 80 patients a day. During the time when I managed clinics, I think the maximum number of patients I could see and really be comfortable with the quality of care I was providing was about 25 to 30 patients. So a doctor or a nurse or clinic officer seeing 80 patients raises questions regarding their ability to provide high quality care. So you would get it and die within about at most 12 years or so. But in the era of ARVs, patients get treatment and their lifespan is equivalent to that of people without HIV because the health system is extremely good at taking care of patients with HIV. So our aim was to reorganize care at the health facility by ensuring that if a patient with HIV comes to the health facility for care, they get all the care in one go, especially for those patients with multiple conditions. So we didn't want the idea of the patient coming in for HIV treatment today and then having to come back 2 days later for diabetes and maybe next week for hypertension. It's too expensive for the patient and also resource intensive for the health system. Because instead of seeing the patient once and you wait for next month before you see them again. You have to really see them again and again and again, meaning that one patient requires the care for 3. But a more revealing thing that I've learned was when I spoke to patients with diabetes specifically about their condition, and they told me they wished they had HIV. And I thought this was a one-off, but I've had this from at least patients from 3 different studies that I've conducted. So the patients who have these conditions will tell you they prefer HIV because HIV has care. Diabetes and hypertension don't have care. And the deeper we go into diet and food preparation, the more we realize that deep frying is one of the biggest hazards to our health. And what is so sneaky about non-communicable diseases is that these things creep on you slowly. But certainly, I think seeing how congested our facilities are, if I had a magic wand, I would dictate that the ministry goes ahead and implements community-based integrated care in some form. Because then it would decongest the facilities and indirectly improve the quality of care for those very sick patients who need to receive their care within the facility, while also reducing costs and improving access for the patients who are stable, clinically stable.
Welcome yet again to another episode of the podcast on Uganda. Today's segment is a special one. It's a segment on reports. Now, oftentimes we have amazing books written, amazing reports written, but where are they? They're stacked, hidden away in libraries, archives. But this segment is really to bring those papers, documents out to life for people like you to understand them, dissect them, and see how we can use that information to help us get into the middle class economy. Now, I'm on this WhatsApp group of international females from several countries in the world, and they're here in Kampala. So one of the ladies was saying how it's nice to be in Kampala where you can just go and get your medicines from the pharmacies. Now, I don't know if that is a good thing or a bad thing, but what is good for sure is that there's a study today that found out that there is a possibility for patients to be treated at home in literal terms, and the study is called community-based integrated care. So now the debate, I think, was about being in hospital or being treated at home. And today we are in luck because we have the Dr. Francis Xavier Kasujja, who is a researcher in public health, and he's here, one of the authors of the study, to help us dissect it and understand it. So welcome to the podcast, Francis.
Thank you, Aggie.
How are you feeling?
Feeling good.
Yeah? Is this your first podcast?
Yes, kind of.
Yeah.
Yeah, though not probably the first time on the screen.
Yes, I've seen rounds. He's taking interviews for this work, but also some other work that he has published in the past. So I really recommend you to try and read these things, because this is where some of the solutions to our problems are. Now, Francis, just to give us an entry into the podcast, what is this study about? What was the overview, the general overview of this study?
Yeah, so the study, which is, as you said, community-based integrated care.
Yeah.
For short, we call it INTECOM, integrated care in the community. It arose from previous work that we've done. So my area of research is non-communicable diseases. These are diseases like diabetes, hypertension, that they are also chronic, but they are defining factor is that they are non-communicable. They are not transmitted through contact or through the air, like maybe pneumonia, measles, or through water. They are transmitted mainly through lifestyles.
Okay.
So depending on the lifestyle, you have either you do physical activity or you don't, or your diet is diverse. We call it dietary diversity, meaning that your diet is composed of so many different kinds of food. So dietary diversity has been associated with good health. But of course, generally speaking, we talk of a balanced diet, meaning that you eat food from different food groups. So that ensures that you have all the needs that your body has met nutritionally. So lifestyles like those promote health and prevent non-communicable diseases like diabetes and hypertension. So that's the area where I work, mainly in prevention, because I'm in public health. So I'm not a clinical researcher, though of course we all work along the lines of diseases, but my area is in prevention and management. And by management, I mean improving the care that people with these conditions receive. So if you look at how the trends that our diseases have been tracking over the years, I could even say over the centuries, in the past, say in the last 100 or so years, we had a lot of malaria, which we still have. A lot of typhoid, a lot of sleeping sickness. So those are the diseases we had in plenty. Those are communicable diseases because they can be transmitted either with the help of a vector, like a fly or a house fly for foodborne diseases. So they can be transmitted from one person to another. So those are the diseases we had. And we had a lot of them, to the point that when the health system that we are using today was being formed, the focus was in addressing those diseases. And what they came up with was what we call vertical programs. For example, a sleeping sickness control program. Or a malaria control program. So the focus was always on that single disease and treating it, and that approach continued way into the 90s when the HIV program was rolled out in our countries. So it's the same approach. You have a big health problem, a communicable disease, you form a program and put all your resources on addressing that. However, over the years, the trend initially of non-communicable diseases like diabetes and hypertension was very low 100 years ago. But because of the changes in our lifestyles, we have seen the number of people suffering from these diseases increasing gradually. So today, if you look at the statistics, 1 in 3 adults, that's about, I think, 34% of all adults in Kampala has high blood pressure, hypertension. So it actually has the larger burden regarding how many people are affected. So you count 3, 1 of them has it. When you look at a disease like diabetes, about 10 years ago in 2014, a nationwide survey was conducted, funded by WHO, determine the burden of diabetes. I think it was about 1.2% nationally, so that's 1 in 9 people.
Yeah.
That survey was repeated about 2 years ago. This time the survey showed that 2.8%.
Really?
So the burden of diabetes had doubled in 10 years.
Yes.
And the way these things work...
No, in 2 years.
In 10.
Okay.
Because the study was done 2 years ago,
yeah.
but it was following a study that was done 10 years prior.
Yeah.
So the idea is to repeat this survey every 10 years in order to be able to track the trend or the prevalence of these conditions. So diabetes, which actually most people are more aware of, our prevalence is still low, but when you go to the hospital and visit the diabetes clinic in the past, these days we are phasing out those clinics, and I'll talk about that in a minute. So if you visit the clinic managing diabetes patients, you'll be overwhelmed by the numbers.
Yes.
Doctors see up to 80 patients a day. During the time when I managed clinics, I think the maximum number of patients I could see and really be comfortable with the quality of care I was providing was about 25 to 30 patients. So a doctor or a nurse or clinic officer seeing 80 patients raises questions regarding their ability to provide high quality care. And that is diabetes.
In that one, for example, one hospital or one clinic?
So it really depends. It's hard to say. One of the challenges of all these diseases, chronic diseases, is that it's very difficult to keep track. To know whether the patient you're seeing today is the same patient you saw last month. Because, again, because of our system, the system was designed to address one-off diseases, episodic diseases, like malaria, like pneumonia. Someone comes, you treat them, they go home, they are well and may not come back in the next 5 years. With these chronic conditions, because you are going to have them for the rest of your life, it means that the ideal way to approach management is for you to keep track. Every patient should have a record which you check and confirm whether they are getting their treatment and they are responding appropriately and whether you need to adjust or maintain that treatment. So we've done very well when it comes to chronic conditions like HIV. So to backtrack a little, HIV is a communicable disease, but it's one of the few communicable diseases that has also turned into a chronic disease. Before the era of ARVs, HIV was like a death sentence because there was no treatment.
There's a lot of stigma also.
Yes.
Oh, I remember those days.
You would get it and die within about, at most, 12 years or so. But in the era of ARVs, patients get treatment and their lifespan is equivalent to that of people without HIV because the health system is extremely good at taking care of patients with HIV. So if you go to an HIV clinic, every patient has a file. That file, depending upon how long they have been getting care in that clinic, can cover as many as 10, 20, 30 years. So the records are there. We know whether that patient has ever suffered from TB and how to ensure they don't get it again. We know whether they have ever had things like pneumonias. There's a pneumonia we call PCP. And how to ensure they don't get it again. So the care is tailored to that patient. It's patient-centered. In the case of diabetes and hypertension, that's not the case, because these conditions have not received the same level of support. And of course, we don't really know how to provide it in this context. So it's a big challenge. So you also find that a patient who has, say, HIV can actually get diabetes or hypertension because these diseases, the risk of getting these diseases increases the older you grow, irrespective. And because people with HIV are living longer, their risk for these conditions increases. But some of the drugs they use for HIV also increase the risk of developing diabetes and all these other conditions.
That is true. I think today everybody in the family has one patient with chronic illnesses. They'll tell you, it's a chronic illness, but chronic illness, where did this come from?
Exactly.
And
so
one of my
it's the
sisters,
lifestyle.
it's a lifestyle, One of my sisters in Florida, she was diagnosed with leukemia, and then she was under remission, and later they found out she has diabetes. So I think it was, like you mentioning, probably the drugs from the cancer.
With the drugs, yes.
Yeah,
so the drugs are, because the drugs change the way your body works, they can easily mess up how the body regulates blood glucose, which increases the risk that the body will fail to regulate it, and then you develop diabetes.
And because there are some internationals in Uganda or our international audiences, I think it would be nice to paint a picture, because in Uganda, when we have a cough, you go to the hospital. And my husband, Mark, is always thinking, just go home and rest.
I know.
You know, that's the remedy. But what are the findings in this study now?
So in this study, what we did, so this study follows on from a previous study. Initially, our aim when we started this work is work we've done with colleagues in the UK at the University College London, as well as colleagues in Tanzania at the National Institute of Medical Research. And of course, my own organization in Uganda is Medical Research Council. So Medical Research Council is really the name we give for convenience. It's actually a Medical Research Council, MRC / Uganda Virus Research Institute, and London School of Hygiene and Tropical Medicine's Uganda Research Unit. That's the full name.
It's a mouthful,
Yes, but we always prefer to give it that way because South Africa has a Medical Research Council and UK has a Medical Research Council. So this is a research unit affiliated to the UK Medical Research Council. So that's our mother, and we still get a lot of support from them. So our aim was to reorganize care at the health facility by ensuring that if a patient with HIV comes to the health facility for care, they get all the care in one go, especially for those patients with multiple conditions. So we didn't want the idea of the patient coming in for HIV treatment today and then having to come back 2 days later for diabetes and maybe next week for hypertension. It's too expensive for the patient and also resource intensive for the health system. Because instead of seeing the patient once and you wait for next month before you see them again. You have to really see them again and again and again, meaning that one patient requires the care for 3. So it takes away from all the other patients that would benefit. So in order to...
Also, I think the time spent in the travel. So just for context, my mom was doing this thing the past 2 months, visiting people in the hospitals, and one day I went with her. These people, she would ask them, where are you coming from? And they would say Mitiana, Bugisu, Karamoja. Some are coming from Sudan. So if they have to come in 2 days, if they say that one has HIV and diabetes at the same time and they have to travel, that's a lot of time.
It's a lot of time, it's a lot of money, and we've done research in quantifying the costs. And we found that actually it's too expensive when compared to patients who come to the one-stop clinic we formed. So in the one-stop clinic, a patient who comes into that clinic is able to get all the care in one go by the same clinical team. They are able to get their drugs for the 3 different conditions, and then they are able to go home. And depending on their schedule, for example, for HIV, sometimes patients get drugs for 3 months. We manage to work with the health system to optimize and ensure that even for these other conditions, depending on the patient's health status, they could actually get all their treatment in that one visit and come back after 3 months to get their treatment for the same conditions. So meaning that they would save a lot the health system would also be able to operate in a more efficient way. So that was a study we published about 3 years ago. Yeah, it was very, very useful. When we did it, we were able to demonstrate that the care that was provided in the new one-stop clinics was equivalent to the care that was being provided in the separate clinics where these patients were getting pre-treatment before. And early last year, following the funding challenges from the withdrawal of USAID funds, the government of Uganda actually adopted the one-stop clinic approach. I wouldn't like to say that it's because of our study, but definitely our study contributed. Because it's probably one of the few studies, if not the only one, that had tried out that model before it was adopted. So following on that study, the current study evolved. So the current study was motivated by the fact that when we looked at the one-stop clinics, the number of patients was so huge. And of course, if you are going to take care of the number of patients, you are definitely going to spend more resources, more time. It's going to be more intense. So we developed a new model whereby we move the same approach of integrated care from the facility into the community. And in this study, we compared our findings in the community after 1 year. So we followed up patients for 1 year within the community where they formed small groups of around 14 patients. And the nurse brought their drugs there. And in the community, the nurse worked with a member of the village health team. So village health teams are lay workers. In Tanzania, they are called community health care workers. In Uganda, we call them village health teams, who are lay people appointed by the village to be the liaison between that village and the health facility. So the VHT would mobilize the patients within their unit, either village or parish, and then they would wait for the nurse. When the nurse came, they would get health talks, and then they would be triaged and monitored and receive their treatment and go home. The whole thing would last about 2 hours, compared to the 9 hours or so that they would have to wait at the facility. So that was the group in the community. At the facility, patients continued with their usual care within the integrated clinics. So after 12 months, we compared the findings. And this new study, it was published recently, about 2 weeks ago, found that the quality of care for patients with diabetes and hypertension was equivalent to the quality of care that people in the facility-based integrated clinic were receiving. And initially, our worry was that by putting patients with HIV patients have very good clinical outcomes, with almost 99% of all patients having achieved control. So once they join the program and are given treatment, their viral load is suppressed. They achieve, we call it viral suppression. So meaning that the risk of them developing complications is markedly reduced. The risk of transmission is extremely low. And definitely they are able to live a very good quality of life like anyone else. So our worry was that by bringing patients with diabetes and hypertension and mixing them with patients with HIV, that's something I hadn't actually mentioned. In these clinics, it wasn't that we were focusing on HIV patients with diabetes and hypertension only. No. We focused on those, but the bulk of the patients were patients with either diabetes or hypertension and without HIV. And we brought them together at the facility initially and later in the community. So our worry was that by bringing these patients together, we were putting the clinical outcomes of the patients with HIV at risk. Because, of course, these programs, like I said earlier, diabetes and hypertension are not as, we don't really have as good an experience of managing them as we do for HIV. And that's something that we baked into our analysis. So our findings showed that we were able to achieve the same level of quality of care for diabetes and hypertension as we had done at the facility, and we achieved this without compromising the care for HIV patients.
Okay.
So when you look at the viral suppression, it remained extremely high in both the community and the facility. In the community, it was about 98% suppressed, and in the community, the facility, it was about 97%.
I mean, that sounds like good news to me because, like we said earlier, if there's a lot of time spent in the waiting queues, I mean, health systems are broken. You hear also in the US that people need appointments for 3 weeks or 3 months in advance, you know? But now that patients can get services from the VHTs, but that's under the assumption that most of these chronic diseases have the same symptoms, that this VHT will know it is and how to manage?
Not necessarily. What we did with the community study was, because of course when you're taking patients from the facility to the community, there are certain risks you're taking.
Yes.
You are taking patients from the facility where they can access a doctor and get routine checkups and laboratory where they can do a few more tests than they can in the community, and taking them to the community where you're asking a nurse who is a lower cadre to provide care assisted by a VHT who is a lay person. So in order to control for that risk, the risk of the care at the community being of lower quality than at the facility, we only took to the community those patients who are clinically stable.
Okay. Yeah.
Yes. And of course the whole study was focused on those patients, meaning because one of the strategies in research is to ensure that if you're comparing two groups of patients, you want those patients to be as similar as possible in all ways, except for the intervention you're trying to do. So in this case, the only patients that were enrolled into the study were patients who were clinically stable. These are patients who had no complications or whose complications were well managed. They are patients who had been in care for at least 6 months. They are patients whose blood glucose and blood pressure had not exceeded a certain threshold within the previous 6 months. And of course, the other thing was that these are patients that were considered adhering to treatment based on the healthcare workers. So by focusing on that group of patients, we minimized the risk that they would get complications or need specialist treatment while in the community. And of course, because the nurse was trained as well as the VHT, and we identified a few cardinal symptoms and signs, and we taught them to recognize them and refer the patient back to the facility. So meaning that the risk of the patient actually getting mismanaged in the community was very minimal. And whenever we found any patient who needed specialist care, we referred them. And of course, in the facility, we allowed the clinical team to decide whether the patients should come monthly, every 3 months, whereas in the community we made it a monthly visit to ensure that if there is anything wrong, we capture it early and then refer them back, and once they are controlled at the facility, they would be referred back to the community.
It's amazing what research is doing and how much you're finding out, especially to prevent, right?
Exactly.
So for context, Francis is a 5 a.m.er. So what does that mean? We work out together, and his wife, and he's dedicated to live the lifestyle he was talking about earlier. Now, even for those workouts that most men actually would say, no, those are for ladies, stretching, yoga, or Pilates, Francis is doing them. But because I see now why he knows the benefit of doing these exercises, especially because if we're not eating enough in our diet, like with all the mixes and nuances of the foods we are eating today, I can see why it's important to keep the movement going. But I must commend the research, because like you have said, we have seen advancements with HIV, and it's really managed with the patients, and the results that are remarkable with HIV, I hope you can also achieve with diabetes along the way.
Yes, we are trying, hopefully.
And so I was coming to the point that Francis himself told me that the president said that we are a pandemic economy. we have benefited from the lessons of the pandemics we've had as a country.
Yes.
Now, for those patriots who are not yet so sure, really, does this work? You have told us you did a multi-country trial in Tanzania. It also worked in the UK. Tell us more about the methodology that you used and how long was this trial for?
Okay. So for this trial, just a point of correction. The funding was UK.
Okay.
The sponsoring institution was UK. That's the University College London, and previously the Liverpool School of Tropical Medicine.
Okay.
But the implementing sites were Tanzania and Uganda. So this is in line with our goals as Respond Africa. So our research group, the consortium, is called Respond Africa. And our focus is on controlling chronic conditions in Africa. So, of course, what we get from the UK, in addition to the funding, is the expertise, our colleagues in the UK, because those countries have done a lot of research in all these things, and they are better placed to be able to coordinate the countries down south, to be able to replicate, but not just replicate, to be able to innovate around the contexts in the south.
They'll tell you that some diseases that are prone to our tropics, they're not so savvy on finding the solution as our researchers or our medics would be.
That is part of the economics of health promotion. So, of course, you mentioned the pandemic economy. I don't think they use the term in the UK or wherever, but one of the biggest industries is the pharmaceutical industries in those countries. Today, you've hopefully heard of these weight loss drugs, the GLP-1s, which are able to reduce actually weight in dramatic ways. And a huge industry has been built around these drugs in those countries. These drugs exemplify the reality of medicine globally, that the people who can pay for treatments, who can afford to pay, are people in the global north. So as a business person, if you want to invest in medicine or in health, it makes more sense to invest in a market that's available. So in Africa, of course, we have the market, we have the need, but we can't afford to pay for these things. So studies like ours are aimed at trying to innovate around those constraints. So we don't want to just sit back and say, oh, we are doomed, we can't do anything about this. No. Institutes of global health like the one at UCL, at University College London, spend all their working hours trying to work with countries in the south and colleagues, of course, in the north, to come up with solutions that are baked around the realities in those countries, such as this integrated care approach. So it's an approach that we can deliver, and we've done studies on the health economics. We are about to publish a paper on the cost effectiveness. And when you look at that data, it shows that actually the community-based integrated care per visit is more cost effective than facility-based integrated care, because patients save a lot of money in transport, in the time that they spend at the facility. So that's time that they could invest into their day-to-day work. And in integrated community-based care, they are able to actually use that time profitably. 2 hours at the clinic, and then you go to your garden until you land. So you don't lose that day. And you don't need, of course, to come back repeatedly in order for you to take care of all the conditions that you may have. So the economics of global health in this case is we find an economics of global health that works for us, which does not involve us having to spend so much money to buy those drugs. But we also know that with time, just like happened in HIV. So if you remember the time of HIV at the beginning, the only people who could afford ARVs were people in the global north and very rich people in the global south. Today, everyone can access HIV care for free at the health facilities, even in Uganda, and I believe in most countries in Africa.
Yeah.
So, but that is a future that we hope for, but can't wait for.
Yeah.
So we have to do something now. And by doing some of these things, luckily, which we have learned from HIV, we are able to accelerate our ability to prevent, ability to promote health as far as chronic diseases are concerned. Yeah.
So now for that patriot who is listening, they want to know proof. What is the proof? Tell us about Tanzania and also the trials you did here in Uganda.
Okay. So the proof, of course, is in the results. So both of these papers that emerged from the two main studies. So we've done other studies, but the two main studies, the one at the facility and the one at the community, have been published in the Lancet. So the Lancet in research in medicine and in research generally, we have what we call impact factors. So an impact factor is the measure of how much a paper or a journal or papers within a journal have impacted the thinking around the subject matter of that paper. So the Lancet has the highest impact factor in the world. So it's the journal with the highest impact factor, with a very high rejection rate. So they receive more papers than they publish. And that is because everyone wants to publish them. But both of those papers, the one we published in 2023 was published in the Lancet. The one that we published recently on the 14th of March was published in the Lancet. So that is, of course, an incredible achievement for our research team. But it also goes to show the quality of the results and the credibility of the results and the ability of these results to impact policy, health policy, in a very positive way. So that's partly the evidence, but of course the actual evidence is in the numbers in those papers. If you look at the numbers in the papers, you will see that these studies are both some of the biggest trials, I could even say globally, especially in the African region, involving non-communicable diseases, and definitely they are some of the few and the largest trials on integrated care globally. So this is work that is cutting edge in a sense. It's work that no one had tried before in the way we did it. Of course, most of the research prior to what we've done was research that was focused on integrating diabetes and hypertension care in HIV clinics for HIV patients. What we did with these studies was to conduct integration for everyone as long as they have those conditions. And by virtue of that, the work that we've done has potential to be used as a platform. So ours was a proof of concept that you can integrate these things and achieve good results. And by doing this work the way we did it and getting the results we did, we are providing an approach whereby other conditions could actually be added. So on top of diabetes, hypertension, and HIV, we want also to add sickle cell screening. One could say, I want to add maybe anemia in pregnancy or something like that. So depending upon the needs of the community and the health system, this platform that we've built can be used to actually, not just actually provide care among patients who have already been diagnosed, but can be used to actually act as a screening platform within those communities. So on the day when the clinic is going to run, other members of the community could be invited for a diabetes test. They could be invited for a hypertension blood pressure measurement. They could be invited for a sickle cell screening, especially young women and men who are ready to be married. So, as speaking as a researcher, I believe that it would be very useful for us to investigate those different approaches and see whether we are able to maintain the same quality of result. So I think this is a very positive thing, especially so seeing that the Ministry of Health has already adopted facility-based integrated care. The next step is community-based integrated care. So we had a chat with the Assistant Commissioner in charge of non-communicable diseases, and he said that one of the approaches that the ministry might explore of using these results is by adding more conditions in an integrated fashion to the outreach program. So the ministry already has an outreach program where they go to the community and do immunization and also provide other services along those lines. So he sees an opportunity here to maybe provide diabetes care, provide HIV care, and care for other conditions. But for HIV, we already have a very, very wide program of what we call differentiated models of care. So these are models of care that move away from a rigid clinic-based approach to an approach whereby a patient's preferences guide the way you deliver care. And there are several different approaches that have been tried. TASO is a leader, a global leader. Globally, they are probably the best in this kind of approach. And they have developed certain models, like models whereby patients, the fast track model, where a patient doesn't need to come and wait in line at the clinic to receive care. They can just, if they don't have any issue, they don't have any complication, they are healthy and they have been taking their drugs well, they just go to the pharmacy, collect their drugs, go home. So that's fast track. And then there are also models whereby a friend within this clinic can actually come on the day they collect their treatment and collect drugs for a colleague who has remained back in the community. That has been done in Uganda for several years by TASO and other implementing partners. And there are also models similar to what we've done, whereby the healthcare professionals go with the drugs to the community, and then the patients within that neighborhood come to a meeting point, say at a church or a school, and then they receive their treatment together, they get a health talk, they get examined, and then they all go back home. So that is the model which inspired us to do what we did with integrated care. But of course we worked with smaller groups because this was a proof of concept.
And I think we'll come to the recommendations later for the policymaker, because what do we do with this brilliant research, right? But for the patriot who's still trying to place their story in our story here,
I know.
I'm sure every one of us knows somebody with diabetes, with HIV, hypertension.
But we're hesitant about doing when we try to integrate was mixing patients without HIV with those with HIV. And our worry was that patients with HIV would be extremely uncomfortable with mixing with other people coming from their village. So in HIV care, there are two things. There is disclosure or non-disclosure. It takes time for all patients to be comfortable with the people around them knowing they're HIV positive. But the other thing is stigma. One of the reasons why it's hard for patients to disclose is because there's a lot of stigma against HIV. In Uganda, based of course on my interaction with colleagues in Tanzania and elsewhere, we're actually doing extremely well as far as stigma is concerned. But still the problem is there. You can't really deny it, especially seeing that in our studies, one thing we saw was that the patients with HIV alone were more likely to be young people, whereas the patients with diabetes and hypertension but without HIV were likely to be older people. So meaning that we were actually putting young people with their parents, with their grandparents, with the elders in the community.
I see that.
So that got us worried, but we were very pleasantly surprised to find that in both cases, both at the facility and community, the consensus was clear. All the patients told us that it didn't matter.
Yeah.
They were not too concerned about that. What they needed was the service. And this is exemplified by the numbers we had. So in studies of the kind we did, usually follow up at the end of the 12 months, you'll usually find less than 50% of patients still coming. In our studies, especially the most recent study, we had a follow-up rate of 95%. So 95 of all the patients came back and we collected data on the end results. So the level of acceptability of this model is extremely high. But going to the take home for the young people, when you interact with the patients with all these conditions, for me, I've done research in this area for like 15 years. And I always, in the past, I used to think that the worst thing that could happen to a young person, because of course when I started I was much younger than I am now, not to say that I'm old now, I'm still young. But I used to think that the worst thing that could happen to me was to get infected with HIV. But in the work I've done, I've actually found a lot of people with HIV empowered. And of course, people with HIV are able to get treatment and live a normal life. Some of the young people out there have HIV because that's the reality in our country. So that should not be seen as a death sentence. So in this day and age, you can get treatment, and the treatment is available at the health facility within your community. So you don't have to come to Mulago for treatment. But a more revealing thing that I've learned was when I spoke to patients with diabetes specifically about their condition, and they told me they wished they had HIV. And I thought this was a one-off, but I've had this from at least patients from 3 different studies that I've conducted. Both the study I started with this work about 10 years ago, the study that I used for my own training, and then my most recent study. Because when you look at the level of care for diabetes, we are just learning how to provide care for diabetes. When you look at the level of complications, they are much higher for patients with diabetes and hypertension. And some of them are extremely gruesome. Sometimes people get diabetes foot and they need an amputation in order to live. Sometimes people get strokes. People get heart attacks, among so many other things. People can get blind. People can get impotent because of diabetes. So diabetes is a disease that affects the whole body. And the same applies to hypertension. So it also has very similar complications to diabetes. So the patients who have these conditions will tell you they prefer HIV because HIV has care. Diabetes and hypertension don't have care. They have the care, but it's not of the best quality available. So, and there is a silver lining in all this story. For all these conditions, be it HIV, diabetes, or hypertension, we know how to prevent them. We have effective ways of preventing them. For HIV, you have to live a really, really careful life. We are the champions as a country of the ABC strategy. In fact, Uganda is one of the few countries globally that was able to see a downturn in the prevalence of HIV before the era of ARVs. So before we received ARVs in our health system, the HIV burden was falling already, simply because of the ABC strategy.
So there was a lot of promotion then about you saw it everywhere on the billboards.
So that strategy worked then, still works today. When it comes to diabetes and hypertension, it's about living a healthy lifestyle. You talked about waking up at 5. So waking up at 5.
We are starting at 5.
is one way of doing it. Other ways is being more active. You don't always have to jump onto a border. every time you need to travel.
I will find Francis. We worked out at 5 a.m. and he'll also be walking in the evening. I'm like, this man.
Exactly. So walk a lot more. So you have to eat healthy. And in our context, compared to in the West, actually the healthiest foods are the cheapest.
Yes. The ones people will be like, I don't eat beans.
Yeah, I know. I get so worried these days when I see KFCs cropping up left, right, and center.
Yes.
And when you go on TikTok and read the comments, people are so proud. I saw a TikTok recently with the new KFC unit in Nansana, packed, crowded with people. And someone was saying, yes, even us people of Nansana can afford this. So people look at it as a mark of achievement. Yet actually fast foods are some of the biggest risks for non-communicable diseases. For diabetes and hypertension we have. But some people think that KFC is the only fast food. The commonest fast food in our setting, and we've done a study on this, the commonest fast food in our setting are Rolexes. Rolexes are fast food. Most people get shocked and look at me the way you're looking at me when I say this, because they see an egg and they see fresh tomatoes and all that. But all of this is deep fried with cooking oil. And the same cooking oil, of course, has been used throughout the day and has reached its smoking point. And the deeper we go into diet and food preparation, the more we realize that deep frying is one of the biggest hazards to our health, to a good diet. And most young people thrive on Rolexes. It's what they eat. They go back home after a busy day. They are too tired to cook for themselves. And then they run and pick a Rolex.
It's just right out. It's right outside the door.
Some of them have accounts at their Rolex place. They pay at the end of the month. And what is so sneaky about non-communicable diseases is that these things creep on you slowly.
They pay later.
You don't feel it. In fact, you will be very happy when you eat these things, because some of the things are the most delicious. So when you're eating it, you actually feel good about it. But then 10, 20 years later, when you develop these complications, it's going to be extremely difficult for you to reverse.
I hope I remember this every time I'm trying to make a bad decision.
So Rolexes, soda, Rock Boom, and other beverages that are so common these days, all those things are extremely unhealthy. And they increase the risk of non-communicable diseases. And remember, you may be able to do the ABC and prevent HIV, and then the diabetes gets you. And from those patients, we've heard that diabetes is a worse sentence.
Really a pity, that you have to compare, wish for one devil.
Exactly. So you have to prevent all these things. You don't have to say, I'll live a very good, positive life as a young person and keep myself in line and avoid catching HIV, and then you go around eating Rolexes and piling mountains of food on your plate. Maybe one day we'll come and just talk about these things. Because they are practical ways of avoiding overeating, of doing a good diet. They are practical ways of food preparation, of stocking your fridge, or not stocking it, what to keep there, what not to. So all those things are really practical. And once you do them, you will be able to control your weight, because weight loss, weight per se, is an independent risk factor to all these conditions. So even if you're not eating Rolexes and all these other things, but your weight is too high, you're at increased risk of not just diabetes, hypertension, but also a lot of other things like cancer, cancer of the large intestine, cancer of the stomach, cancer of the throat, so many other things. So all these things move together, but lucky for us, they share preventative measures. So a good diet, physical activity, are very good at reducing the risk of all those conditions. So that's why those two things, on top of other things like reducing stress. So stress can also increase the risk of at least diabetes and hypertension.
Yeah.
So if at all you're able to really live a positive life, and of course exercise and do yoga. Yoga is one of the exercises that has been shown to actually reduce blood pressure. We normally encourage patients with high blood pressure to do aerobic exercise. It's quite good, but also yoga, and of course exercises along the lines of psychometric exercises and things like that.
I'm always very honored that I get some of this. Can you imagine all this knowledge in the morning, 5 a.m.? So I find myself very lucky, and now to see that you're also sharing with the patriots, that you made time for this. Now, you had already alluded to the fact that the ministry is already actioning some of the earlier study findings. Now, I don't know from your position, if you had the magic wand and you would dictate who gets to use this information, how would you want them to use this, especially in a policy perspective?
So, we've had talks with the ministry, expressed our desires and heard from the ministry, and of course it's an ongoing dialogue. So one thing I didn't mention is that the studies were conducted in collaboration with the Ministry of Health in Uganda and the Ministry of Health in Tanzania. And the research questions as well as the study designs were informed by the ministry. So the ministry told us this is what we could implement. So instead of testing so many other ideas, design a model in this way, because if this works, this is something we should be able to implement. So if at all you ask me if I had a magic wand, definitely, but of course it's difficult for me to really go out of the way and become wishful. I already know what the ministry thinks. But certainly, I think seeing how congested our facilities are, if I had a magic wand, I would dictate that the ministry goes ahead and implements community-based integrated care in some form. Because then it would decongest the facilities and indirectly improve the quality of care for those very sick patients who need to receive their care within the facility, while also reducing costs and improving access for the patients who are stable, clinically stable. So I think that would be a very, very good approach. However, I'm also cognizant of the fact that policy things require so many other things to be in place. They require restructuring of funding and of even the ministry itself. For example, if they said we want to do community-based integrated care, they would have to create a unit within the ministry, hopefully, or at least have dedicated personnel to make sure that it's done properly. That's what they have done with facility-based integration. So there is a ministerial integration task force that is helping with rolling that out. So, of course, before that one is fully rolled out and we know everything is working well, it would be a little bit risky for them now to say, now we're also going to do community-based integrated care. But at least the evidence is there. We've provided the evidence. We are working with the ministry. Hopefully, when the time comes for the ministry to roll this out, we will still be available to work with the ministry to ensure that it's rolled out properly. Oh,
that was brilliant. Thank you so much. I always leave with such conversations. My head is buzzing with information that it's too much at that point. But I hope I can digest it slowly. Now we have the very last question for every guest that comes onto this podcast. And this is a rapid fire question. So 2 questions in one. One is, what are we currently doing in your sector, your space, that will help us achieve that thriving middle-class economy, right? And what are those things we are doing currently that we should stop because they're not taking us anywhere? The first one, what are we currently doing that we should continue?
So my sector is research, medical research specifically. Uganda is one of the topmost countries in sub-Saharan Africa and globally in producing medical research. In fact, if you look at Makeray's ranking and you look behind at the back and to see where that ranking is coming from, it's one college that stands out, the College of Health Sciences.
Okay.
So most I don't know what percentage, but I could even dare to say 80% of all the rankings or the points that contribute towards that high ranking are from the College of Health Sciences.
That's bold.
So a lot of interesting things are going on in medical research. And I think that's something that we should continue doing. And I do some teaching myself, both at Makeray. I supervise students and elsewhere. And I always feel really, really encouraged when I see young people very interested in doing medical research, winning small grants, and improving their understanding of medical research.
Wonderful.
What shouldn't we continue doing?
That is one of the... We need 3 answers. For
what we're doing properly.
Yeah.
So another thing we are doing properly, at least with my research group, collaboration with the Ministry of Health, all our work is informed by the priorities of the Ministry of Health, as well as the priorities of patients. So before we do any work, we always go to patients and ask them, what is it that we can do to make your care better? How can we work together to make this work? And I believe by doing that, we are able to deliver research that is not only informed by our context, but is also aligned to the priorities of the Ministry of Health. So I think that's a very, very big positive.
Yes.
Number 3, what are we doing well? So another thing that the government is doing very well over the last couple of years, probably 5 or 6 years, the government, through Makeray University, created the Research Innovation Fund. And the amount of money allocated to this fund has been increasing steadily. I don't remember the actual values, but I remember initially it was about 3 billion shillings, and today it's probably much more than that. And that money is given to researchers within Makeray universities and other public universities to work on their ideas, research ideas, and test them out and write papers, which projects are informing the government's approach. And of course, during COVID, we saw how much money the government was investing. At our unit, at the MRC unit, we have at least one study that the government funded, and we've developed a prototype vaccine for Crimean Congo virus. There are so many viruses with such strange names. And that's one of them. So we've developed a prototype vaccine using government funds. So I think that's something that the government should be applauded for, and something that should continue. More and more funding. We don't have to really run to the UK for some of these things. We should be able to have them funded using taxpayers' money in Uganda.
Wonderful.
Yes.
Now, the things we need to stop. We need to stop doing them because they will not lead us anywhere.
So the things, do they have to be research based?
Your choice.
Okay. So the things we should stop, I've hinted a lot about Rolexes. For me, I don't want even to go a high level and say, stop eating fast foods. No. I want to be specific and say, stop Rolexes, stop Rock Boom, stop soda. People love soda. But soda is extremely destructive and addictive. I know of so many people who are addicted to Coke. So eat healthy. I will put exercise together with that. Or should exercise be number 2? So let's have exercise as number 2. Please go out and exercise. One of my colleagues at the Ministry of Health uses an example of mopping the floor. So if you have a tap that is flowing, and then you have a mop, the most logical thing to do before you begin mopping is to close the tap. So prevention is key in all of this. The good diet, the exercise, we are going to continue getting all these health problems. And of course, the positive living and avoiding getting HIV infected.
Yeah.
We are going to get infected, we are going to get diabetes, hypertension, and other things. The health system is going to be overwhelmed, and we'll always complain that the government is not providing enough diabetes drugs.
Yeah.
Whereas when you prevent, this morning I was listening to a podcast, and someone was saying you choose your pain. Prevention is painful. Waking up at 5 to exercise is difficult. There are times when I say, no, no way. Then last minute I jump out of bed. Because to exercise at 5, you have to wake up at 4:30. But then, that is one sort of pain. But the pain of having your foot amputated is far worse.
May you remember that.
Is far worse than waking up at 4:30. For me, those are the things that inspire me. Because I know what the condition looks like. So I would rather wake up at 5. I would rather be tired, exercising and sweating profusely. I would rather eat food that may not be as tasty, but is healthier, because I know in the long run that's an investment. Yeah.
Wonderful. Last one, those are 2. Eating, food, and exercise. What's the third?
So the third thing that we should avoid doing.
Stop immediately.
Is implementing, I'm now going to get a little bit high level. Is not to do evidence-based policy. So there is a lot of evidence emerging from work like mine and other researchers. Uganda has some of the best researchers globally. I have a lot of colleagues from Tanzania, from Cameroon, from Ethiopia, with whom I do research. But everyone, and I've worked in several countries. I've worked in South Sudan, I've worked in Zimbabwe. I remember when I went to Zimbabwe so many years ago, about 15 years ago, to work. The moment I said, I'm a Ugandan doctor, consistently, even deep in the village where I went to work, they would always tell me Makerere University. Everyone knows Makerere University. So, and the reason, of course, they know it is because of its outputs and because of the research that comes out, not just in health, research in nutrition, research in engineering, and a lot of other things that in agriculture, we have a very vibrant agricultural courses that we do. So I think that's a missed opportunity. Not to say that the ministry is not using research, because I've already given examples where this is happening, but I think this should be encouraged, and the ministry should work more closely with researchers, because of course the researchers know more about the evidence available, but the reverse is also true. The researchers should collaborate more in order to improve our economy.
What a great way to end. You had it from Francis, the man himself, our doctor. He said he doesn't want to be called a doctor, but I think you have these titles. You put effort and work in it, so we should acknowledge them as they are. So thank you so much for your time. I hope you have taken out one thing, dear patriot, at least. Leave that Rolex and fried foods alone.
I know.
Thank you very much.
Thank you, Aggie, for hosting me.